This explainer is based on postural orthostatic tachycardia syndrome, or POTS, a vestibular physician's deep review of diagnosis, pathophysiology, and management, published by Australian Dizziness Clinics.
Welcome back to this explainer, tailored specifically for vestibular physicians and advanced specialists. Today, we're really shifting how we look at POTS. We're not treating it as a single disease anymore. Instead, think of it as a final common pathway of autonomic dysfunction. You see, that exact same orthostatic tachycardia sitting in your waiting room right now, it can actually spring from completely different underlying mechanisms. And understanding that difference, well, it absolutely changes everything about what works for your patient. So, here's our clinical roadmap for today. We'll start with a universal core mechanism of POTS, then we'll branch out into the 4 pathophysiological subtypes, look at where they overlap, and finally summarize our clinical next steps. Let's dive in.
Section 1. Introduction to POTS as a final common pathway.
Moving on to Section 2, let's establish our anchor, the core mechanism.
To really grasp POTS, we first need to look at how normal orthostatic physiology completely fails. Normally standing up requires this beautifully synchronized dance, baroreflex responses, sympathetic vasoconstriction, cardiac output regulation, all working perfectly together. But in POTS, that whole system breaks down. Let's walk through exactly what happens. The moment a patient stands, gravity yanks roughly 500 to 800 milliliters of blood straight down into the splanchnic and lower limb venous beds. In a POTS patient, this causes a drastic, sudden drop in central venous pressure and cardiac preload. So what does the body do? It panics. It fires off this massive compensatory sympathetic surge just trying to fix that low stroke volume. And the direct result of that panic? Excessive tachycardia. Now, this exact gravitational redistribution, basically all that blood pooling in the legs when they stand, perfectly explains those 2 major symptom clusters your patients are always complaining about. On one hand, that reduced venous return leads directly to cerebral hypoperfusion. That's your classic brain fog, the dizziness, the extreme crushing fatigue. But on the other hand, that aggressive compensatory response we just talked about leads to adrenergic overdrive. And that is what's causing the heart palpitations, the anxiety, the tremors. It's essentially a vicious loop. And the kicker? Things like physical deconditioning and low blood volume will just amplify this entire cycle.
Okay, Section 3. Let's talk about the branches, neuropathic and hyperadrenergic POTS.
So now we branch out. We know what the loop looks like, but what actually kicks it off? Let's look at how this exact same orthostatic tachycardia can spring from totally different sources. The most common mechanism we see in clinic is neuropathic POTS. This stems from a partial loss of those sympathetic vasoconstrictor nerve fibers that supply the legs and the splanchnic bed. Essentially, the veins in the lower half of the body are literally denervated. So when the patient stands up, there's just totally inadequate peripheral vasoconstriction. The blood pools excessively simply because those vessels aren't getting the signal to squeeze. Oh, and you'll often spot abnormal pseudomotor findings here too, like a noticeable lack of sweating, especially down in the feet.
Conversely, we've got the hyperadrenergic phenotype, and this affects about 10 to 15% of POTS patients. Now here, the primary issue isn't loose vessels in the legs, it's an overfiring sympathetic system. These patients exhibit massive sympathetic excess. You'll see pronounced tremors, severe anxiety, and even labile hypertension the minute they stand up. Interestingly enough, in some families, this whole shebang is actually driven by genetic loss of function mutations in the norepinephrine transporter gene. Basically, it leaves way too much noradrenaline just hanging around in the synapses.
So just take a second to notice the contrast here. It's really a tale of 2 entirely different failures causing the exact same rapid heart rate. Right? Neuropathic POTS is a failure of local constriction, something you'd often confirm with small fiber neuropathy on a skin biopsy or an abnormal QSRT test. Hyperadrenergic POTS, on the other hand, is a massive excess of central sympathetic drive, which presents with a highly elevated noradrenaline response.
So the million-dollar question, how do we actually prove this biochemically? Well, to formally confirm the hyperadrenergic subtype, we're looking for standing plasma noradrenaline levels to exceed 3.54 nanomoles per liter, or 600 picograms per milliliter. Hitting that 600 mark, alongside those standing provoked symptoms, of course, is your definitive biochemical flag for sympathetic excess. Moving on to Section 4, let's delve into the hypovolemic and autoimmune subtypes.
All right, we've covered the nerves and the sympathetic drive. Now let's see what happens when the tachycardia springs from an empty physiological tank or from a totally misdirected immune system. A huge number of POTS patients suffer from hypovolemic POTS, and it acts exactly like a car trying to run on an empty gas tank. These patients have a demonstrably reduced circulating blood volume and impaired renal sodium retention. Plus, they often have these paradoxical, blunted renin-aldosterone responses. Because their central venous pressure is so remarkably low to begin with, that core orthostatic loop we talked about earlier, it's massively amplified the absolute second they stand up.
And then we have the autoimmune phenotype. Now, you've probably heard a lot about this one lately, right? It's been heavily spotlighted due to that massive surge of post-COVID autonomic dysfunction. In autoimmune POTS, the body basically mounts an attack on itself. It produces autoantibodies against ganglionic acetylcholine receptors, beta-adrenergic receptors, and muscarinic receptors. What usually triggers it? Often, it's molecular mimicry right after a viral infection. The immune system just gets confused and mistakes the autonomic nervous system antigens for the invading virus.
You know, distinguishing between these specific mechanisms is absolutely vital for your management plan. For example, here's a massive clinical pearl for you. If a patient has hypovolemia POTS, remember, the empty tank, and you mistakenly treat their tachycardia with high-dose beta blockers without addressing that volume issue first, you can actually completely tank their exercise capacity and make their symptoms way worse. They don't need their heart rate forcibly slowed down. They need fluid loading, sodium, and fludrocortisone to actually expand that plasma volume.
Which brings us to Section 5, the overlap zone, where we synthesize all of this. Because, let's be real, in the actual world of your clinics, patients rarely read the textbooks, do they? When we look at those 4 primary mechanisms, hyperadrenergic, neuropathic, hypovolemic, and autoimmune, we see that they actually all share this central overlap zone. And this overlap is defined by those universal features of orthostatic tachycardia, a baseline of daily symptoms, and crucially, physical deconditioning. Deconditioning is a shared amplifier across the board. It worsens the cardiovascular atrophy and stroke volume, no matter which of those primary quadrants the patient originally sits in. So it's really crucial to burn this number into your memory, roughly 30%. About a third of your POTS patients are just not going to fit neatly into one little box. They're going to experience an overlap of these subtypes. That means you might find yourself having to manage an empty physiological tank right alongside a neuropathic denervation issue at the exact same time.
Now consider this your ultimate clinical cheat sheet. It breaks down the exact targeted biomarkers you need to differentiate the branches. You're going to use QSART and skin biopsies for neuropathic, standing noradrenaline over 600 for hyperadrenergic, plasma volume assays for hypovolemic, and specific receptor autoantibody panels for the autoimmune subtype. Identifying the correct biomarker literally unlocks your targeted management plan.
Finally, Section 6, Summary and Next Steps. To wrap up this explainer, let's quickly review how this entire pathophysiological framework actually translates into our broader clinical approach. The vital takeaways are pretty clear. First, the foundation of POTS is always venous pooling and that resulting compensatory tachycardia. Second, figuring out whether your patient fits into the neuropathic, hyperadrenergic, hypovolemic, or autoimmune subtype, or maybe an overlap, completely changes what therapeutics are actually going to work. And finally, and honestly most importantly, these classifications are there to guide rather than replace your overall clinical picture. You're treating the whole patient, which means always addressing that deconditioning that's amplifying their unique loop. So we've unpacked the hidden autonomic mechanics. But what does this actually look like when a patient is sitting right in front of you? Well, in part 3 of this explainer series, we're going to take this exact science straight to the bedside. We'll explore the specific orthostatic symptoms, the systemic associations like vestibular migraine and GI distress, and that exact clinical pattern that flags POTS in a busy, real-world practice. You won't want to miss it. This has been an Australian Dizziness Clinic's Vestibular Physician Review. Make sure to visit AustralianDizzinessClinics.com for the full literature review and to grab your clinical cheat sheet. See you next time.